will we learn from future observational studies? So not too much time spent looking back, but rather forward. And does anyone here, you would have to be 70 or 75, remember the Grand Smog of London? Richard Peto, yes. Kuhn Teo, Jeff Probsfeld, great. And this occurred in 1952. It was 5 days when London went dark, and it was due to this kind of perfect storm of coal, fire, burning plants, the weather conditions, and the way London is situated its topography. And what happened during this time was the hospitals were filled up with people complaining of severe respiratory ailments. And during that period of time, 12,000 people died. So there have been many analyses of this and adjustments for, are we sure it was due to the acute grand smog? And after adjustment of many things, it is correlated that yes, these 12,000 deaths occurred during the grand smog of London. Now, in 2018, in the Journal of American College of Cardiology was a state-of-the-art review kind of declaring that ambient air pollution causes cardiovascular disease, and all of these pathways are well illustrated. And that's why I was so intrigued by the last session, where we still are trying to figure out, is ambient air pollution causal with respect to cardiovascular disease? And if we look at our traditional approaches to epidemiology, we typically start with a question, and in the case of air pollution, we could go right back to the early 1950s, and then we begin a series of studies to try and determine if the factor is causal. And they can be animal studies. You expose rats to air pollution, you put some rats with a filter to prevent them from breathing in the air pollution, and you see how long they live. Smaller human studies, larger human studies, typically called cohort studies in high-income countries, and then more recently, global studies that can now include low and middle income countries where the exposure levels of ambient air pollution are much greater. So if we believe that from 1950 to present day, we have confirmed air pollution as a risk factor for cardiovascular disease, and we still hear today some uncertainty about that, that took 70 years. If we compare cholesterol as a risk factor for cardiovascular disease, the same types of studies were undertaken, although different types of studies were possible. So we have animal studies. These are knockout mice where they have high levels of LDL cholesterol, and then they're sacrificed and they're shown to have more atherosclerosis. Large population studies, such as the Framingham Heart Study. Feeding studies where we feed individuals high-fat diets and we measure their lipids. More recently, genetic studies, first starting with family-based genetic studies, linkage studies, then moving to GWAS studies, demonstrating likely causality. And then with LDL cholesterol, we were able to do randomized trials. So the 4S trial back in the mid-90s, high-risk secondary prevention trial demonstrating that simvastatin prevents cardiovascular death by lowering LDL cholesterol. So if we look at that timeline, it's about half that of air pollution, perhaps we could say 35 years, but that's still quite a long time. So when we think about the future, are there ways in which we can narrow down or shorten the time between the question or hypothesis and proving causality? So I'm going to show 3 examples today of observational studies in the modern era. And the first one is one that I co-led with Dr. Matthias Friedrich and the late Dr. Jack Tu, called the Canadian Alliance of Healthy Hearts and Minds. And the goal here was multifold, but we started off by saying in Canada, there's an east to west gradient for mortality. So people who live in Eastern Canada have higher mortality, and as you go west towards British Columbia, it's lower even after you adjust for cardiovascular risk factors. we were interested in knowing what the burden of subclinical vascular disease was using magnetic resonance imaging. So this is called an imaging biomarker. As well, we were interested in cognitive function and focusing on special populations, those high-risk populations for cardiovascular disease, including First Nations people of Canada. And we began this initiative in 2012, and presently we're now at the point where we can open up access to researchers outside the investigative team so that they can apply and utilize the data. I mentioned that we had a number of objectives, and we started off with a cohort of 11,000 people using somewhat innovative ways of recruiting them. We recruited cohort participants who are already part of other cohorts, and they consented and completed their questionnaires online. We then were able to get their consent to record link their health card number to enable us to collect mortality and hospitalization data through CIHI. We then also set out to audit about 2,000 communities across the country for the nutrition environment, tobacco environment, physical activity environment. And now we're at the point where we can layer on top of that publicly available air pollution measurements to individual communities by linking to postal code. Now, we also, as I mentioned, built in this very specific imaging biomarker. So of the 11,000, over 8,000 of our participants came into an MRI center and had either an MRI at a fixed MR center, or if they lived in rural or remote regions, we drove the MRI machine to them. And our main outcomes of interest were silent brain infarction, such as lacunar infarct or cortical infarction, intraplaque hemorrhage in the carotid artery, a number of measurements of cardiac disease, LV function, LV mass, as well as looking at visceral adiposity in the abdomen and fat in the liver. And thus far, we've begun our investigations and publications, first off showing that simple counting up of risk factors through the Interheart risk score or Framingham risk score is associated with subclinical vascular disease on MRI, and all of these outcomes I've mentioned, intraplaque hemorrhage, silent brain infarction, and all of these together we call MRI-detected cerebrovascular disease. We also measured cognitive function using two common measures in many of our PHRI studies, the digital symbol substitution or DSS and the MoCA. And we looked using the MRI classification at what happened to cognitive function as individuals had more silent brain infarction. And amongst individuals with 3 or more silent brain infarctions, they had a 9-point reduction in their DSST, which is quite substantial. And the majority of these silent brain infarctions were the cortical brain infarctions. We then put into a model other factors that may determine low cognitive function. And when we do that, we can see that, yes, our silent brain infarctions are important predictors. This is now the population attributable risk as opposed to hazard ratio. The non-lacunar stroke, high white matter hyperintensities. All of these are measurements from the MRI. When we put in the burden of cardiovascular risk factors, you can see that it accounts for a much larger proportion of the population attributable risk. And also interesting was the protective effect of post-secondary education. So when we put this into the model, we can see the more education an individual had, the greater protection they had from lower cognitive function. So when we look at it this way, we can think of the high technology certainly helping us understand the why of low cognitive function, but it's also important from a societal perspective to see that the more post-secondary education an individual has, the greater protection they have against future reduced cognitive function. Now, I mentioned that we involved and partnered with First Nations people of Canada. There are over 1.5 million First Nations people in Canada who live across 600 communities. And in our study, we partnered with 8 communities from British Columbia to Nova Scotia. And they participated in a modified version of the Alliance Protocol, modified based on their own interests and cultural values. And within this 8-community study, we recruited 1,300 First Nations participants. They had a much higher average inter-heart risk score, so a greater burden of cardiovascular risk factors. And we wanted to try and understand what protected some First Nations communities from having a very high risk score and what made others quite high risk. And so rather than do a First Nations compared to non-First Nations comparison, which is the traditional model that always makes our First Nations people's health outcomes look much worse, we compared between the First Nations communities. And we can see that there are a number of factors that were associated with a higher risk factor, such as low access to care, difficulty getting prescription medications, also the cost of the medications. And then there were some protective factors. So greater education an individual had, more social support, and also higher socioeconomic status were protective factors. And I have this little symbol in the corner to also demonstrate that from this collaboration with First Nations communities, in which they consented to provide a DNA sample, one of my colleagues has been funded by Genome Canada to now create what's called an Indigenous Reference Variant Library, so that when Indigenous children are being diagnosed for possibly having a rare disease, their whole genome sequence can be compared to a reference whole genome sequence that comes from Indigenous people, which does not exist today. Now, I mentioned that our partnership with First Nations peoples was a partnership. We were ready to send back each community their own data last year. And at that time, they said to us, we are concerned about security of the data in our community, and we're not sure the best ways to analyze our data. So we brought all of these communities together to the PHRI, and with Shrikant's leadership and also an Indigenous facilitator, we had an Indigenous data workshop that was a great success, and our community leads left very excited about future collaborations and use of our data together. Now, the second example I'd like to give is the UK Biobank, and many of you will be familiar with the UK Biobank platform and probably use it. And it started out, and many of us reviewing the initial protocols would have said it seems to be a data thin cohort. A data thin cohort is where a large number of people are recruited, and typically questionnaires and physical measures are used. And the data is thin because you don't have a lot of additional measurements, such as wearable devices, etc. But the UK Biobank has actually transformed from what was once called a data thin cohort to a data thick cohort. And by that I mean, yes, they recruited 500,000 people with questionnaires and physical measures, but they've been able to go back and collect additional information. So that includes 100,000 individuals having a complete body MRI, with plans to bring back 70,000 of those people for a repeat MI. All of the cohort has been genotyped, so GWAS-Y genotyping is completed, whole genome sequencing is underway, as is metabolomics and record linkage to primary healthcare data. And the beautiful thing about the UK Biobank, apart from it being large, having a large number of clinical events, is the goal is to make this publicly available. And they've done an excellent job in making that possible, with over 700 papers published from UK Biobank data to date. And they're working really hard to decrease the time between application to use UK Biobank data and a researcher receiving it. And I believe it's down to about 1 month between application and receipt. The third example is a US example called One Brave Idea. And some of you may be familiar with this, funded in part by the American Heart Association, Verily, and AstraZeneca. And there was an open competition and researchers were invited to submit their brave ideas. And this competition was won by Callum McRae from the Brigham and Women's Hospital in Boston. And he received $75 million with the kind of big tagline to cure coronary artery disease in 5 years. And this is a different approach. Rather than a large cohort with multiple clinical outcomes and high power, he is going kind of under the skin with very deep phenotyping of sensors, GWAS, whole genome sequencing, likely metabolomics and proteomics as well, to try and understand why some people don't develop coronary disease and why others do. Now, I haven't seen much published from this cohort or study at this point, and it may pay off, but I would consider it a high-risk investment because it focuses on a single disease, whereas cohort studies, you can measure multiple different diseases. Now, we've heard at our last panel session, how could we do better than a food frequency questionnaire to measure diet? And we probably all are hearing about the omics. So the promise of omics are measures that we can make beneath the skin. So it could be your gut microbiome, bacterial composition of various body fluids, blood tests, in addition to questionnaires, anthropometrics, and then integrating all of this data measured in individuals. If we take the example of diet, some of you will be familiar with John Ioannidis and his provocative writings. And he did a systematic review of all the dietary studies. And in 2018, he said, nutritional epidemiology is in need of radical reform. Eating 12 hazelnuts a day would prolong life by 12 years. Drinking 3 cups of coffee a day would achieve a similar gain of 12 extra years. And eating a single mandarin orange daily would add 5 years of life. And he goes on to tell us about the bad things and our loss of life. Could this be true? Seems a little bit of a stretch. So now we can think of more precise measures of markers that circulate in our body that may reflect our diet. And this is called metabolomics. And we recently completed this study where individuals were randomized to either a Western or prudent diet, and then in their blood and urine samples, we can then subject that to mass spectrometry to come up with what the kind of biochemical profile is in each individual. And what we can see are there are relatively few yet robust markers. For example, individuals who eat citrus fruit, shown in the green, have a higher concentration of proline betaine. Individuals who eat lentils have another marker called tryptophan betaine. So there are about 4 or 5 fairly robust markers of diet that may allow us to have a more precise metabolomic signature. Now, with all of the omics data, what will we do with it? We have omics, electronic medical record, lifestyle data. This is what people refer to as big data. But the caution with big data is just because we have more of it doesn't mean the way we analyze it will be less biased. So we still have to think about study design and potential biases. There are some innovative analytical techniques, such as instrumental variable analyses, but you can't use that in every question you're asking because sometimes the instrumental variable doesn't exist. The challenges of observational studies are not reduced by the large volumes of data, and therefore we have to think of novel designs and novel analytical techniques. A small word on artificial intelligence, it certainly has a role. The most kind of demonstrable role thus far has been to increase the efficiency of some of our analyses. To give you an example from our MRI study, a human tracing the left ventricular volumes would take about 150 days to read our 8,000 MRIs. Whereas with AI, once you train the computers, you can cut that down to 3 days. So that's an example of how AI can make our data analyses more efficient. And second to last is, I don't want us to forget about the importance of social class and social factors. So zip code matters more than genetic code when we relate these to health outcomes. The closer engagement of social epidemiology with formal causal inference approaches is what social epidemiology is called. And the challenge with social epidemiology is, what do we do when we know low income, low education, low social support are associated with higher rates of disease? It's much harder to think about a randomized trial of those factors than it is to do a randomized trial of drug A versus placebo or drug A versus drug B. There have been some randomized trials. There's ones that are well known, such as the Moving Toward Opportunity study in the US. There was the Ontario Basic Income Pilot that unfortunately was terminated early. And I challenge us to think about these very difficult problems and get good people and young minds to think about innovative ways to evaluate trying to change the social trajectory of individuals and communities in order to reduce diseases. So to wrap up, observational studies of the past had challenges such as imprecision of exposure and the time lag between the hypothesis and trying to confirm causality. Future observational studies use new approaches that may increase precision and possibly shorten the timeline. A good model to go forward with, I believe, is the data thin, thick cohort, such as the UK Biobank, also called personalized population studies, which are large, enable above and below the skin approaches, and likely are the way of the future if they encourage open access and maximize its use by other researchers. AI can play a significant role in analysis with some cautions, and novel study designs are essential for faster solutions to population and societal health problems. So thank you very much, and this is a credit to all the people I work with. Thank you.